We're excited to be here today on our tour of communities around the country, communities where primary care and family medicine are making health primary. Our campaign, Health is Primary, is collecting and sharing stories of innovation that are driving the future of healthcare in America, and you'll hear just a sample of the work that's being done here in Detroit and across the state of Michigan. I'm Glenn Stream. I practice family medicine in La Quinta, California, and I'm president and board chair of Family Medicine for America's Health, a newly established coalition of 8 national family medicine organizations. These groups represent all aspects of family medicine, physicians in practice, in research, medical education, and academic medicine as well. Family Medicine for America's Health has come together with one mission, and that's to improve health in America. As everyone knows, our nation is facing a health crisis. We have the most expensive healthcare system in the world, and yet our citizens don't enjoy the health that they should. Before I go on, I'd like to briefly thank folks that have been involved and can by no means, especially with this big of a group, thank everybody, but I want to call out a few folks that have been especially involved in helping us, our effort, which is, this is our 5th city tour site. We're going around the country, but we always want to connect with local folks that can help us identify the issues and the people. So I want to thank the Greater Detroit Area Health Council, particularly Dr. Soretti Markova, and then being a family physician, I have to call out the Michigan Academy of Family Physicians, their executive director, Deborah McGuire, and their current president, Dr. Kim Yu. So thanks to all of them for their help. Also like to tell you what's going on in this corner over here, just to tell you about how family doctors keep it in the family. Our artist is Tess Tabalik, niece of Michigan family physician Tim Tabalik, who's a longtime friend of my wife and I, who's a family physician. And she is completing, as we're doing our event, a painting that is graphically depicting family medicine here in Michigan. So I hope you'll take a chance to look at it at the end, but it really displays what family physicians do from, many of our colleagues attend births and obviously take care of people throughout the course of their lifetime. It's time to put the health back in healthcare. We believe that the solution to many of our healthcare problems can be found in primary care. We're so convinced of it that we built the Health is Primary campaign to make the case to patients, payers, and policymakers that a strong primary care system will allow us to deliver on the promise of the triple aim: better health care, and reducing costs. The evidence for primary care is strong and speaks for itself. We know that access to primary care can help us live longer, healthier lives. In areas of the countries where there's more primary care providers per population, death rates for cancer, heart disease, and stroke are lower, and people less likely to be hospitalized. An increase of just one primary care physician per 10,000 population can decrease costly and unnecessary care. Outpatient visits decline by 5%, inpatient admissions by 5.5%, ER visits by 10.9%, and even surgeries decline by 7.2%. Evidence shows that primary care is associated with a more equitable distribution of health within populations. U.S. adults who have a primary care physician have 33% lower health care costs. Medicare spending is lower for states that have more primary care physicians per population, and those states have more effective, higher quality care. Health, quality, and cost. That is the triple aim we must achieve, and we believe primary care can best deliver it. So what does healthcare look like in America when health is primary? We believe it looks a lot like family medicine. And we want to ensure that whether your primary care provider is a family doctor or not, that you live in a place where health is primary. A place where patients and doctors work together in true partnership. Doctors have long-term relationships with their patients and see and treat the whole person. Technology supports and fosters the connection between patients and doctors. Everyone has access to a medical home where if not all of their healthcare needs are met, and a coordinated medical neighborhood for those additional care needs. Prevention and health promotion are as important as treating disease. Doctors that work with community leaders to address individual and population health. Health disparities are reduced by increasing access to primary care, and financial incentives line up with good care and better health outcomes. Today you'll hear from our panelists about their practices and their work to ensure a solid primary care workforce in Michigan. Their conversation today will focus on different aspects of their work and innovations that are helping them drive results for patients and communities across the state. While these stories may seem different, there's a common theme. They all focus on delivering continuous, comprehensive, coordinated, and compassionate care, the model of primary care we believe and know can help transform our health care in America. Ensuring a strong foundation of primary care is what's going to help make us healthy again. In addition to our work to spread the word about primary care delivering better health, better care and lower cost, we want to do the work necessary to scale and accelerate the pace of transformation. That's why, in lockstep with our work on Health is Primary, we're working with other primary care groups, policymakers, and payers to enhance and modernize the primary care system in this country. We'll be forming multidisciplinary teams to expand access to the patient-centered medical home, to improve use of technology and practice efficiency and patient care, recruit the best and brightest to primary care specialties, and shift to a comprehensive payment model that rewards value over volume. It won't happen overnight, and we can't do it alone. We're inviting all our colleagues in healthcare, payers, employers, patients, and the broader medical community to join us in this cause. And we're collecting and sharing models of innovation that are going to help make America a place where health is primary. And that's what today's session is all about. I'm going to turn our conversation over to our moderator, someone who knows and has seen firsthand the ironclad rule that primary care is the foundation of healthcare systems that deliver for patients and communities around the world. T.R. Reid has become one of the nation's best-known reporters through his books and articles, documentary films, reporting for the Washington Post, his commentaries on NPR's Morning Edition. T.R. Reid has written 9 books in English and working on a new book right now that's really probably foremost on his mind as well. Written 3 books in Japanese and translated 1 book from Japanese to English. He understands healthcare. His 2009 book, The Healing of America, a survey of health systems innovation around the world, became a national bestseller, and his film, U.S. Healthcare, The Good News, highlighted stories about parts of our system that are working. And since that is what we're trying to do with Health is Primary, he's here to help us tell these stories of primary care and family medicine efforts that are delivering in this state. And now I'd like to turn it over to Tom so he can lead a discussion amongst our panelists about the exciting work to drive a culture of health here in Michigan and around the country. Tom, please.
Thank you. Hi, everybody. I am just delighted that you're all here today, and in addition to that, I'm delighted that I'm here today, because for me, this is coming home. I currently live in Colorado, and I'm a proud Coloradan. As you probably know, we're the highest state in the country in more ways than one. But I grew up in Michigan, so I think I'm an actually certified, is it Michigander or Michiganian? Which one am I? So I got 2 different answers there. I think it was Michigander when I lived here, but that was a long time ago. When I lived here, there was only 1 Henry Ford hospital, so you know that was a pretty long time ago. And I always thought, boy, Michigan in October was pretty awesome. When I was growing up, every October, the scout troop went to the cider mill. Do you still do that? Yeah. We used to ride the Boblo boat to Belle Isle. Does that still happen? Still go to Belle Isle? Yeah, yeah. Here's something strange. When I lived here, well, the big house only had a mere 88,000 seats. That's a long time ago. And when I lived here, Michigan always beat Michigan State. This is ancient history, is it? I think. And the Red Wings were powerful. They won the Stanley Cup like every other year. And nobody here but me will remember this, but the Red Wings had the best line, the best offensive line in hockey. It was called the production line because it was from Detroit and because they scored so many goals. That was, anybody who was growing up in Michigan at that time knows, Gordie Howe, Alex Delvecchio, and Ted Lindsay. You remember? Fabulous. Those were great days in Michigan. And while living in Michigan, going to high school, I learned to ski at some tiny little hillside up around Plymouth or something. I wonder if that place is still there. I think it had one rope tow. And after a couple, 2 or 3 years of struggling on that hill, we went up to Boyne Mountain, and I thought it was the highest place in the world. I just couldn't believe anything was that big. So now I live in Colorado, and yeah, I've seen. Anyway, so I grew up here, but I left Michigan, and as Glenn said, I went around the world. I was a foreign correspondent and lived on various continents, and got interested in healthcare. And that's when I started looking at health systems around the world, and was kind of disappointed. I mean, as an American, to come upon this startling fact, all the other countries like us, and I mean by that advanced, high-tech, free market democracies, all of them are doing better than we are at this basic task of keeping people healthy. They have better health outcomes, they spend about half as much as we do, and most important, they cover everybody. They provide health care for everybody. There's only one industrialized democracy that doesn't cover everybody, and that's the United States of America. We are trying to fix this. We're looking for ways that we can get better care at lower cost so that we could cover everybody. And that's one of the key reasons we're going around the country talking about primary care. Because when I'm a reporter, I used to go in and see health ministers and economists, and when I was traveling the world looking at healthcare systems, I asked the healthcare ministers, what's the right ratio of doctors, of specialists and primary care doctors? What's the proper mix? And all of them agreed that the right mix was about 2 primary care doctors for every 1 specialist. And of course, the United States has that upside down. We've got this backward. And that's a major reason why our country spends more and gets less than any other rich country. Because as Glenn said, this is an ironclad rule of health policy. Everyone knows this. When you put more emphasis on primary care, you get better health outcomes at lower cost. It always happens. And that's what we're trying to encourage with this campaign. And I think it was essential that we come to Michigan because this state, among health policy types, is really known for collaboration, for collaborative efforts among different specialties, among payers.
Chief Medical Officer at Blue Cross Blue Shield of Michigan, and I'm responsible for our professional payment policies and our medical policies that relate to what we cover and how we pay for it.
Hi, I'm Jean Mallowan. I'm a family physician with the University of Michigan, also with Blue Cross Blue Shield. And I'm the medical director for the Michigan Primary Care Transformation Project, which is one of the CMS demonstration projects, multi-payer demonstration projects.
Hi, Kathy Budnar. I'm a regional health director for Dow Chemical, and I'm an occupational physician and general internist, and I'm here to share how Dow supports primary care. And there's 3 general areas where we do this. One is our on-site occupational health and health promotion programs. The other is through our benefits plan design And the third area is advancement of health of our communities.
Hi, good morning, everyone. I'm Jenny Hughes. I feel like the least qualified up here on the panel, my esteemed physician colleagues to my right. I am the Executive Director of Oakland Southfield Physicians. I work to administer approximately 350 independent primary care physicians here in Southeast Michigan, and I'm privileged to join the panel on behalf of the Greater Detroit Area Health Council and share a little bit about what we did with the Greater Detroit Area Health Council in relation to trying to improve what was trending in the wrong direction, our ER utilization.
Fine, thanks. So Dr. Zimmer, I wonder if we could start with you and you could tell us about the collaborative, the value partnerships, the collaborations you're doing, and the movement towards the patient-centered medical home.
Well, thank you. We've been on the partnership journey for about a decade now. And probably about a dozen years ago, it was very obvious healthcare wasn't on the right track. And one of the sort of core reasons was that our payment model did not support a high-performing healthcare system. It created restrictions and limitations that actually confined the delivery of healthcare in a manner that was not really allowing us to deliver value to our customers and not really allowing the people who were practicing medicine to deliver the full value. So we thought, how do we create a high-performing healthcare system, recognizing that our payment has to change, but recognizing that in order to achieve that goal, we needed to have a strong primary care foundation. We needed to have a coordinated rather than a fragmented delivery system. We needed to have a focus on population-level performance. And we also needed to have greater focus on process measurement and improvement, recognizing that the literature of safety in healthcare is the literature of process failure rather than failure of professionalism. So with that start, we thought, well, how do we go about this? And we were invited to go to the Michigan State Medical Society, where the physician organizations in the state were all meeting together and said, partner with us. And really, to me, that was the groundbreaking moment. And it's one of the things that has made a difference between the path Michigan has taken and others have taken, because the physician organization's role, as Jennifer will tell you, has been the key role of facilitating practice change and transformation and building the infrastructure for information exchange, performance measurement, and performance improvement. And so this vital partnership between the payer to align payment and the physician organizations has been the story of the last decade. And I know that on this journey I've pitched pup tents with a fair number of the people in the audience as we've tried to figure this one out. So when we talk about the Primary Care Foundation, we had very high aspirations, but we had a desperate situation. And I would typify it as, for the primary care physicians, it is difficult to soar with eagles while being fed like turkeys. And that was really the point. So what was the concept that we had to go toward in terms of creating a high-performing primary care foundation? And there were two themes that were important. The first was the concept that the primary care practice had a relationship with the patients that it extended across time and across settings of care. And that issue of really being with your patient across the settings of care was where we didn't have the infrastructure to carry that out. The second concept is that the practice model was being confined by the fact that everything that you did had to be according to the exact description of a CPT code and nothing more, because your entire business model was to provide the CPT described service for less expense than the CPT service was paid by the insurers. So everything was a game of sort of reducing the cost of the service, individual service, without any sort of adjustment for the fact that some services needed to be beefed up and changed so as to achieve more effective results in the bigger picture and in the longer run. So the practice model that we were really thinking of was the one described by the chronic care model, which is the office visit is no longer an office visit, it is a productive interaction between an activated and informed patient and a proactive, prepared healthcare team. And I think when you think about that concept, a productive interaction between an informed, activated patient and a proactive, prepared healthcare team, that was exactly what we didn't have. And that's exactly what we needed. So, and that had been well described mostly in the West Coast. And so the physician organizations needed to partner with the plan to have a sustainable payment model for that practice model. And I think the more you think of the challenges of really making that practice model reality, you realize that the first decade is the first of many decades. Because creating a real performance system for primary care where that practice model defines what we do every day is a journey for the long haul. And I think we've made tremendous progress over the decade, but I think it's still true that we have a long way to go to creating a performance situation where the primary care practices are operating according to that theme. And I think that Dr. Malawan's role, and she'll tell you about it, has been exactly in that direction, creating that proactive, prepared healthcare team and the model that supports it.
Thanks. Is that what your transformation program is doing at U of M?
Yes.
Jean? Yeah.
Yeah.
Tell us about it.
Yeah, so well, I'll start kind of at the beginning of this project, which started when CMS issued an RFP. I think it was in 2010, saying what we're going to do is we're going to take state applications that will bring multiple payers together, had to include Medicaid, had to include 50% of the commercial market, and we'll also pay an in-kind amount. And what this is for some sort of patient-centered medical home demonstration. And one of the things that we've always realized in Michigan is we have a very unique environment here. I think we have the physician organizations that Tom spoke of are really kind of, I think when you're trying to do large-scale transformation, you really need some type of convener like that. You can't do it with individual practices. And so we were lucky in that we had this well laid out foundation to be able to do a large-scale project like this. And second thing we had is there's a lot of collaboration in this state that doesn't have, there's competition, but there's also a huge amount of collaboration, quarterly meetings that are convened by Blue Cross Blue Shield where people get together and talk about what they're doing. And we had a lot of things going for us. What we didn't have was a multi-payer patient-centered medical home model. So we had the Blue Cross model, which is the largest regional model in the country, and at the time we had about almost 500 practices when we put this application together. And the other payers in the state had also been very supportive of primary care and patient-centered medical home, but not really funding a common model. And we thought, this is our chance. So we got together, and Sue Moran, who's back there at the table, I'm pleased to see her here. She was one of the original co-directors with me, along with Carol Callaghan, and Mary Ellen Benzik, who's sitting next to her as one of our associate medical directors. So we went and met with all the payers and did a lot of negotiating and lobbying, and we ended up putting together an application that we submitted to CMS, and it was actually a lot larger than they had stated their maximum was in terms of the number of Medicare beneficiaries. But we thought, what the heck, all they can do is tell us to scale it back. But our plea to them was, if you want to really start talking about large-scale transformation, there's nowhere else but Michigan that you're going to be able to do that. So they bought that. They said, okay.
So how many patients was it?
It's about 1.1 million patients.
Oh, wow.
So which is about 1/10 of the population of the state of Michigan.
And they were thinking of like 800 or 5,000 or something?
Yeah. The other states that submitted applications were significantly smaller than ours. So they said, okay, we're going to give it to you, but we're going to be watching you like a hawk. So that scared us a little bit. But so the next thing we wanted to do is say, okay, how do we really start to make this team-based care happen? And we had a fabulous foundation in the state with patient-centered medical homes and a unified model, and we could describe exactly which, based on the Blue Cross data, what practice had what things in place. But what we didn't have is a funding model for care coordination for non-physician care coordination folks, so care managers. And that's the thing that we really thought, okay, all these practices, some of them are doing it to some degree, but there's really no funding model for it. So now's our chance to actually put care managers in these practices, and not just RNs, but we also, you know, the funding can be used for pharmacists, social workers, nurse practitioners, physician assistants, who are functioning not in a provider role, but in a care coordination role or a care management role. And so the next thing that kept me awake at night was how are we going to train all these people that needed to be trained when this is a new model that really no one knew anything about. Everybody was excited about it, but they didn't really know how to do it. And we didn't know how to do it either so much. But so what we did is we partnered with Geisinger Health System in Pennsylvania. They had a program that had been in existence for a long time. And they helped us develop an initial training program, which we have subsequently sort of claimed as our own. And now we teach it regionally around the state. And so it consists of several days of didactic training and then ongoing curriculum, webinars 2 or 3 times a month, and then we have also regional in-person meetings where we focus with the care managers on teaching a specific skill. And so what we wanted to do at the end of the day was say, okay, we need, if we're actually going to test this care management model, we need a relatively standardized model, because the problem when you look at the literature is they lump all these things together that are remotely called care management, and then they draw conclusions from them. So what we tried to do is really take the common elements that were emerging from the successful models, and things like close partnership with the primary care physician, attention to medication reconciliation, attention to transitions, in-person visits along with telephonics. So we tried to make those really strong component of our program. And so it has been very exciting over the past, so originally it was a 3-year demonstration project, and CMS extended it for an additional 2 years, so we're going through the end of next year. And it's been very gratifying to see the survey results over the past, we survey the care managers every 6 months. So how are your physicians accepting you? Do you feel like you're able to do your job? Do you have, Tom's big thing, do you have a workspace? So there were a lot of things that we didn't anticipate were going to be barriers to this, but it's been very gratifying to see those surveys become more and more positive. And so that's kind of what the majority of our intervention is. We tried to resist just focusing on the highest complexity patients, because I always think of that triangle of population health where there's the healthy ones on the bottom, and then you get more and more complex as you go up the triangle or up the pyramid, and there's always people moving up that pyramid, so you don't want to just focus on the ones when they get to the top, but you want to focus on prevention, you want to focus on early diabetes interventions and things like that. So we've really also emphasized and had a requirement of registry support for population management. So,
you have any data on health outcomes or on costs?
Yeah, well, the data that we have, CMS has contracted with Research Triangle Institute to do the evaluation on the Medicare patients, not the rest of the payers. But so we do have data showing cost savings that's been published after year 1 of the project of about $148 per member per year across the whole Medicare population, and that's a return on investment, I think, of about 2.7. So that's a net
fabulous
savings.
Yeah.
And what we've seen over the last 2 years is unpublished data that has showed significantly higher savings, but that I can't really talk about here because they're not for public release. But so we also have Michigan Public Health Institute is also doing an evaluation across all of our payers, and that we hope will be out preliminarily either the end of this year or early next year. And what we've been focusing on this year is, there's always the low-hanging fruit in this population are always the frail elders, the complex Medicare patients. But what we're really trying to focus on this year is making this model work for all of our stakeholders. So what an HMO patient may need looks a lot different than what a frail elder might need. So making sure that we're meeting with our payers, our participating payers, and finding out where their pain points are, what they think we could help them with, and really rounding out the model in that way so that it will be sustainable over many years.
Yeah.
I have Blue Cross Blue Shield of Michigan PPO data to complement what Dr. Mallowan just said, and that is that the baseline year was 2011. In 2011, the practice, these 400 some practices were $7 per member per month higher than the non-chosen practices.
Yeah.
By 2012, they were the same. So that's $7 per member per month. This $7 change has persisted through 2012, 2013, and 2014. And the interesting thing was, because the control group is the PCMH practices that don't have team care, it was an intervention group as well. And they sustained that advantage despite the fact that the so-called control group's cost on a per member per month basis fell over the 3-year interval. And so there is absolute validation that patient-centered medical home is a lower cost care model, and the more that you get into team-based care within that model, the more impactful that cost reduction is.
Well, so $7 a month per patient, 1.1 million patients. We're getting a significant savings here.
That was the Blue Cross component, which I think maybe 30%. I don't know what our percentage of the total
I
is.
think
Three
it
or
is about,
400,000 people.
30.
Yeah.
Yeah,
Yeah.
exactly.
Yeah, it was real results, and
Real results.
yeah,
I'd say so.
on a scale.
So since it's working, shouldn't everybody do it? What do you think?
Well, we definitely think so. One of
Yes.
the, I think one of the barriers that we've actually had, well, 2 barriers. One is that not all of our payers in the state of Michigan opted to participate in this. They had all signed letters of agreement, well, not non-binding letters of agreement that they would participate. Not all of them did. We do still have a majority of patients participating, or payers participating, but so that's been a barrier. And then the other barrier has been, as Tom and I talk about all the time, within the Blue Cross Blue Shield PPO, many of the self-funded customers have not opted into this. So although Blue Cross is totally supportive of this, it's not for all of the patients. It's for slightly over a majority of the patients, over 50%, but still not all. So that makes it a burden in the practices because not all the patients have this benefit.
Thank you. Kathy, what are you finding at Dow? You're a big employer. You pay for a lot of people's health care.
Yeah, we've actually adopted a philosophy back around 2004. We developed a health strategy with 4 main pillars. One is prevention, quality, healthcare system management, and advocacy. And that really evolved over the next couple years to realizing that we really need to work with the community. We get our employees from the community. We want to attract and retain employees from other areas to come to our community, and healthcare in our community is really important, and outcomes are really important, making sure the population's healthier. So we've done a lot to support primary care. One of the initiatives was to get a collaborative body up and running in the community, and initially it was organized for health information exchange, but and it's called MHIA, Michigan Health Information Exchange, and that was changed in the last couple years to health improvement, and that's been the focus. MHIA was really, Dow provided leadership and funding to form this collaborative body, and it really united hospital systems in the community, physician practices, and businesses, and they've been doing a number of projects. They're funded through the Triple Aim, through the IHI Triple Aim. Recently, there's been a diabetes prevention program modeled on the CDC program that's kicked off in the community, and our on-site health centers are involved in this community project. We have a community grant for this initial kickoff, but Dow is working with a number of insurers to ensure the sustainability of the diabetes prevention program. to make sure that there's adequate billing codes so that this program can continue after the grant is completed. So we're doing a number of things, both with our benefit plan design and also in the community.
Are other big employers in Mejia?
Oh, yes.
Yeah.
Probably our the largest employer actually in our community is our local hospital system. And, you know, it's taken a while for everybody to really come to the table, you know, in an energized fashion, because, you know, you're really talking about, you know, changing the way, you know, the healthcare business has been done for a long time. Yeah, but they're coming along. We do have other employers in the area engaged.
And Dow would hire a doctor, would hire you to oversee its employees' health because you want them healthy, or to save money, or what is it?
So, all of the above.
All of the above. Yeah.
You know, I think one of the things that's become clear in, you know, probably our basic level why Dow hires healthcare professionals is compliance purposes. There's regulatory exams that have to be done, and you know, that's probably how Dow started hiring healthcare professionals. But then if you take the next layer, you know, so that's kind of the worker protection layer. But then enhancing worker health, you know, is kind of the next layer. And I think, you know, decades ago, Dow saw, you know, the impact that the programs that we have can have on the employee health and safety. And safety is a huge factor for companies. It's a huge focus, but I really think in the last few years, there's been a very strong connection made between health and safety, and companies cannot get to the level of safety that they want to get to without taking health into consideration. We did a look at some of our work-related illness injury data and found some associations, and you know, it doesn't mean causality, but certainly associations with different health factors, chronic conditions, substance abuse, weight, things like that.
Got it.
So it's definitely important. We had an analysis done of our health strategy efforts, and the analytics showed that our population compared to peer companies had a 9% improved health risk profile, 17% less prevalence of chronic disease, and a 17% decrease in spend on chronic disease.
Wow.
So this is after 10 years of our health strategy, so we feel that we're getting somewhere.
Yeah, it sounds like it. I'd say so. So we've heard from three physicians representing different parts of the overall pattern of healthcare in Michigan: the payer, the educator, the employer. And Jenny kind of wraps all that up into what is this Greater Detroit Area Health Council?
Yeah, you know, we've heard a lot about transformation, we've heard about collaboration, and I think what I was asked to come and share with the group this morning was really what the Greater Detroit Area Health Council convened. And they convened, as Tom said, all of the stakeholders around a table. They convened the health plans. They convened the purchasers of insurance, and they convened the clinicians and the providers. And they sat around and what can we do different? What can we do better? Where do we need to improve? And the group realized that, you know, we had an opportunity when it came to primary care treatable conditions going to the ER. There were probably patients that were going to the ER that didn't need to. And that knitted nicely with the work of the medical home model, with the work of the payment reform, with the concept of team-based care. So naturally, who'd like to try this with us? And so we have a tendency to say, oh, sure, we'll try it. So the physician group that I work with said, yeah, you know what, let's build a model, but let's keep it simple. I'm struck as I listen to my colleagues, I see the green sign over there, see the forest and the trees.
Yeah.
I wake up every day and I look into the eyes of the primary care physicians, or I hear their voices on the other end of my phone going, what? What's next? What do I have to do, Jen?
Yeah,
I said,
yeah.
all right, we can do this together. It's gonna be okay. And that's really what we did with this stoplight, is we kept it simple. We walked in, we said, what are some things anybody can do? How can we talk to our patients? Can we make sure they have your phone number on their smartphone? Can we just tell them it's okay to bother Dr. Malowin? She would rather you bother her than go to the ER. The great story of the mom. My infant, my newborn coughed. Off to the, it's
Yes.
a cough.
Yeah.
You know, but she heard, if you think this is a life-threatening emergency, proceed to the nearest ER. That was life-threatening to her, right?
Yeah.
So, you know, making it real. And so, you know, we did that in a way that wasn't too transformative, wasn't too big and scary, but we went with a group that was trending, actually, I wish I could say down, up, 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 up to this little group that we knit this program together with. They were running, and we first took the sample about 49.3 visits per thousand. We did these little exercises. In 3 years, we got them to 7.3 per thousand.
Wow.
That's a dip.
Yeah.
That's a dip.
What's your stoplight?
Stoplight is a way that we can resonate that message to drive home what really is an emergency. Paint the practice. We have posters, we have laminate, we have websites. We invite at any and all places. You will help us to plaster that up. Green light, when to come see your doctor. Yellow light, I can't get to my doctor, but I think I can wait. Maybe I'll go to an urgent care.
Yeah.
And of course, red light, what is a life-threatening emergency that should probably proceed directly to the hospital. So one of the neatest stories we've had lately is I was working with a community hospital, and they said, Jenny, we are so excited. We just redid our ER. It's gorgeous. People are coming here. I said, really? That's great. Okay, can we talk about that a little bit? And that takes us into that neighborhood idea, because they were like, yeah, maybe, maybe that's not, okay. Let's rethink, you know. So that was kind of just within the past couple months. So.
Yeah, that's cool. That's
Yeah,
great.
thanks.
So we've heard from this really diverse group, but all pushing the notion of collaboration among doctors, patients, payers, employers, et cetera. Really quite interesting. I should have said this earlier, but does anybody have any questions? We have a little time left for questions, if there is a question here. While you're thinking about it, I want to tell a story, but I really like this stop sign to determine when you're supposed to go to the doctor. Which reminds me that last January, it's important, last January, I woke up one day and my leg was purple. My right leg was purple. It was really weird, kind of grotesque. I couldn't figure it out. It didn't hurt. I was walking fine, but you know, my thigh was purple. It was kind of strange. I didn't know what to do. So I thought maybe it would go away. I went to bed. I woke up the next morning and my whole leg was purple. I mean, it looked terrible. Disgusting, and my daughter got really scared and said, Dad, you got a big problem here, you know, go to the emergency room, get an MRI, go see some expert on this, you know. And I didn't know what to do. I didn't have a stop sign. I didn't know what to do, and I mean, which specialist do you go see for a purple leg? You know, a dermatologist,
The left or right?
oncologist, I had no idea. But I do know one doctor. I don't have him on my smartphone, but I think I ought to. My primary care doctor, my family doctor, Grady Holder, is a family doctor in Denver. He knows me. He doesn't know me as an organ or as a broken limb. He knows me as a person. So I went in to see him, and you know, I showed him my purple leg, and he said, pull your pants up, you're fine. I said, what do you mean fine? My leg is purple. And this man knows me. And he said, well, you're a snowboarder, aren't you? I said, yeah, I am. I learned in Michigan many years ago. And he said, well, we had a big dump up in the mountains on Monday night. I bet you went up Tuesday with your snowboard. Yeah, I did. And I bet you fell. Yeah, I did. And he said, well, you broke a blood vessel. That's what you're seeing here. It's going to heal itself in about 2 weeks. And if you're still purple a week from now, you better call me again. And of course, he was absolutely right. I went home and it went away and it was fine. Now, if I had followed my daughter's advice, if I had not had a stop sign, if I'd gone to the emergency room and had an MRI, I would have spent thousands of dollars for my insurer. This visit cost me about 28 bucks, probably cost my insurance company another 80 bucks. This is the virtue of primary care. They can make these, they can just stave off the kind of outrageous costs that have driven our health spending so high when it's not necessary. So that's why I like the stop sign idea. At some point, go see your primary care doctor. You don't have to run out and get an MRI in the first shot, right?
That's a great story.
Yeah.
So purple leg goes under the green.
Apparently, we'll take that. Yeah, purple.
Go see your
leg.
doctor. But I was almost headed to the emergency room. It was pretty disgusting, really.
We have a microphone if anyone does have a question for one of our panelists. So.
Yes, sir.
Hi, Eric Sky. I'm wondering, as you think about the MyPick data and you think about primary care transformation, I'm sure a lot of those savings come from specialty services. And what is the role of the specialists in the whole MyPick transformation, and how have they kind of impacted the processes going on?
Great question. So the model that we built actually had 4 tiers, and the top 3 tiers had to do with transitions of care, moderate care management, complex care management, but the bottom layer was really the medical neighborhood. And that sort of, as everybody's thinking about organized systems of care and accountable care organizations and the SIM grant that is going on in the state of Michigan right now, I think there's a real emphasis on the fact that we don't function as an island and that we have to interface with all of our, the community around us, not just, specialists, the hospitals, the emergency department, and build those bridges. So we wanted to acknowledge that in MyPick, that that is important, and that what we found with the care managers is that they're a lot of times doing the coordination between the primary care office and the outside entities that the physician doesn't have time to do, and the patient certainly doesn't know how to navigate. So I think that is a very important part of how we're going to actually continue to generate more cost savings, is that we need to be able to communicate, we need to share test results, we need to, and this brings, I know we had talked about IT interoperability is a big problem, and people repeating tests just because they don't have the results that the primary care doc did. So I think we have some work to do in those areas, but it's a very important part of transformation.
I'd like to add to that. This whole concept of the primary care practice coordinating care across settings of care is a real challenging topic that has a lot of dimensions that range from health information exchange on, but a lot of it is a new personal relationship between the primary care physician and the specialist. I was talking to the physicians in Port Huron a number of years ago, and I was saying, we really need to start this dialogue, and a primary care physician stood up and said, with all due respect, how can you say that with a straight face? The specialist will eat us alive. And that was a common viewpoint. I went back there 3 years later, and she couldn't even remember having said that. One of the roles of the physician organizations is that we need to bring the physicians who are part of different silos together for a conversation. And I meet very frequently with the specialty societies, and I always ask, what is, in your line of sight, the best way to improve health care? And every time I hear a suggestion for what is upstream to that specialty. So when I go to the radiologists, they say, if you really want to improve healthcare, improve the ordering by emergency department physicians of imaging studies. And so I say, oh, that does sound like a really important thing. How have you discussed this with the emergency department physicians? The answer is always the same. We never have. When we talk to primary care physicians, they say, I don't like how I get the communications back from the specialist. When we talk to the specialists, they say, I don't like how the lack of information I get from the primary care physician. Where are these conversations between and among them, and where should they occur? And the American College of Physicians put together a great document on the patient-centered medical neighborhood where it talked about how the primary care practice is part of a sort of a community of physicians or a neighborhood of physicians. Let's get the people talking. And that is a role that I think the physician organizations play in in convening and bringing people together, but it's kind of astounding how something so basic had been so completely absent from our performance.
Doctor?
I think we have a chance for one or two more questions. Sure.
Congratulations on what you're doing. I mean, it sounds what you're doing great. I mean, primary care, I mean, has been proven over and over again internationally. 1/3 of primary care physicians in Michigan would retire the next 10 years. So what do you do if you don't have doctors here? What are you doing? I mean, we're still producing left brain neurosurgeons, right foot surgeons, and others. Where's the primary care pipeline for Michigan and for this country?
Well, I actually think we have some of our panelists on our next panel that may be more direct to that question, but any of our current panelists want to?
Just very briefly, if you don't resource primary care in a manner that's reasonably equivalent to how specialty care is resourced, you can't solve that problem. It's really that simple. And it is a very complex thing to solve because it just happens to be true that primary care physicians generally will accept a payment far lower than what the specialty care physicians will accept. And part of this is market-based. No one pays more than what people are willing to deliver the service at. And so it's a complex thing, it's a very difficult thing to solve, but it can't be solved if primary care is paid at a far lower level. That's my view.
Yeah, and I'll just add to that. I think it's actually, there's two components to the problem. One is payment, and the second is lifestyle. And so I think, Blue Cross has done a fabulous job, as have the other payers in the state, about being supportive of primary care and trying to actually transform the way that primary care is paid. I think the team-based care model, physicians aren't used to functioning as part of a team, but if they kind of let go of that, I know we've done a lot of, my colleagues from U of M are here, glad to see you, and we've done a lot of team-based care work at the University of Michigan, and once you get these processes in place, it really does make the lifestyle of a primary care doc feel more manageable and feel like there's people that are doing things that you don't necessarily need to be doing at 8 and 9 p.m. in the evening. So I think that's twofold, and I think we're making a lot of progress in this state in both areas, hopefully.
Time for one more question. Yeah.
Yeah, hello, I'm Lisa Mason from the Greater Detroit Area Health Council, and I want to thank Jenny Hughes for representing us so well. But I couldn't resist the opportunity with all this talk about the stoplight poster, just to let everybody know that it's available for free to download from the GDAC website, gdaahc.org. And also there's a guide for primary care physicians listing very simply, just like Jenny described, some of the easy things a primary care physician can do to make themselves more accessible to their patients. Thank you for giving me the chance to make that comment.
Do you have one here, Jenny? The stoplight poster?
I do.
Yeah.
I just it's folded. I'm probably
Well, unfold it.
violating, like, the rules. Yeah.
Mistreatment.
Foundation dollars to print the poster, print this in large posters. If you want any for free, we can get them for you in different sizes.
It's definitely a stoplight, yeah.
It's definitely a stoplight, and I think it, thank you, Lisa. I don't have the public service announcement committed to memory, obviously. But it really, and I feel like I'm a patient, obviously, as we all are.
Yes.
And when I talk to the primaries that I'm so honored, and I see many familiar faces in the room here today as well, when I work with them, they genuinely understand that we don't want to be patients, we want to be people, and we want to live our lives as productively and with the most optimal health we can outside. As much as I like, Dr. Zimmer and Dr. Mallowan, I really don't want to be running to their offices. And we know that as patients, we have to understand that for us to achieve the vision in that video, we have to be more responsible for our health, but pointing fingers and making us not feel comfortable asking the kind of questions so that we really understand, because I'm really good at nodding. I'm so refreshed, and it's such a privilege to hear what the programs are that these just professionals have brought to the state of Michigan for us to be able to do. Our local community organizations like GDAC. The next panel is going to knock your socks off with what they are doing to really, I think, infuse the needed air in primary care. at the end of the day, I think we all really just want to see that brighter light of health, you know, for our family and our society.
Tom,
I misread our schedule. We have more.
Yeah.
We have about 5 more minutes.
Can I ask you, what was the role of doctors in dealing with the problem with the drinking water in Flint?
Oh, okay. Others may have some more direct information, but for those of you who haven't heard this, first of all, this is a really interesting case because it reminds us that the health of our patients and the health of our communities is first and foremost related to things that go beyond what we deliver in our offices. You have to have safe and healthy drinking water, food supply that is safe and nutritious and healthy, and a lot of things are more basic needs than health care, although at times health care can be the one most basic need. But in reality, from the public health perspective, there is no priority higher than safe and clean drinking water. And the city of Flint, as everyone knows, is very short on resources. And they were being charged more than what they could afford for Detroit-based drinking water. So they elected to switch from a more expensive water source to a lesser expensive water source. And they didn't have the resources to perform all the functions to make sure that that water did not have a corrosive effect on all the pipes getting it to the homes. And the corrosive effect of the water liberated a lot of lead into the drinking water and created a public health issue that was very serious, with children having significant developmental impacts. And that was brought to the attention of the public health arena through the standard lead levels that are performed, I think, annually on children, and they started to show high, and the physician community became quite activated to say this is a problem we must solve. And I heard that 3 days ago they switched back to the Detroit water supply for now, and then they'll ultimately go to Lake Huron, but they're still going to have to make sure that that water is treated to prevent its corrosive effect on pipes, because the lead didn't come from the river, the lead came from the pipes on the way. But I think it's important that if healthcare costs get too out of control, they squeeze out the other social supports for things that are really relevant to health. And so we have to be very conscious that part of saving money is not just lowering healthcare costs, it's making room for the other determinants of health to be addressed in a very impactful way by our public health entities, municipalities, and so forth that have that function.
Yes. Yes, ma'am. Right. Yeah.
Hi, thank you all. I have a question just about access, and it seems like with the Affordable Care Act, so many new patients are in the healthcare system that we're struggling to accommodate these. And I specifically with Jenny, with your program, which I think is wonderful and terrific, and I'm definitely going to go download that. I think, have you noticed a problem with access when you're encouraging patients who are green to come into the office and not go into the ER? I mean, obviously, it's better for the healthcare system, but how do your clinics address and manage that increased access?
The access was, and it was different depending on which doctor you spoke to, which staff member you spoke to. So it became standardizing access, and it became looking at the different, and we've heard team-based care discussed as well. Through it, let me try to kind of walk down and knit together what we've been able to do to improve that, because it's a huge issue for us. Building off of the awareness and understanding what are the access points and where can we make changes. We reached out to our community to try to go to that little broader view. Do we have some urgent care facilities in the area that we have strong relationships with, that we have good care coordination and communication? Then we moved a little further and we started to knit in some of our care managers and our care coordinators. So they became another extender. So there's only so many primary care and so many hours in a day to go along. So it became a more blended model. And we also worked through some other programs, specifically with some of the clinics in the city of Detroit, with extenders who were more lay folk that we're also able to help the community knit back into that primary care practice, having gone through the appropriate education. It's not a silver bullet. If a poster was all it took, would we have a problem? We would not have a problem if it only took a poster. But it was interesting because the Friday at noon before a holiday, every appointment was always booked no matter who called. That was interesting. Doctor had no idea what was happening at the front, who was answering the phone. They were in control of what got in. So bringing everybody together in a safe way made such a difference, such a difference. Does that help? Okay. And those samples of what those protocols look like are also available for review.
And, just to add to that, one of the things that we found has become a common problem with patients is that they don't realize that there's a doctor on call after hours. And one of the things, for instance, with the PCMH model, and in particular with MyPick, that was a requirement. You had to have 24/7 access to a clinical decision maker. And all of us at U of M who take call, sometimes patients just want to know it's not an emergency and they can wait until Monday, or that they can go get some, Tylenol over the counter or something. And so educating people and having that on your phone line and having brochures in the waiting room that really just let people know there's someone that they can talk to if they need to makes a tremendous difference in helping with access problems.
I think we probably have time for one more if there was another question, or we can move on. Oh, sir, there you go.
So I just was wondering, I've worked with Jenny before and worked on a lot of this stuff, and we talk about millions of dollars of savings and that type of stuff. So I guess my question is, I'll throw it out to the whole panel and people can just comment on it, is, the payment structure is going to have to change. We have 2-to-1 specialists, and we need to switch that around. And the savings that have come from the ER visits, that's less money that the hospital's getting, right? So then, hospitals want to keep themselves in business too, so that's a problem. I was just wondering how, as there's going to be people that fight this type of change just because it's going to impact them financially, and does anybody have strategies on how to work with that?
Well, having a strategy is one thing. Actually carrying it out is another. And so sometimes I worry about having a strategy for that reason. But the key behind your question is that the payment model has to align us so that we can partner. The role of the health plan should not be to step on the brake while the role of the physician is to step on the gas. That's the way the fee-for-service system went. So really you need to have something that takes you away from that, so that the payment model has people doing what they aspire to do, which is having good outcomes and having well patients, but also achieves the results for the customer and the plan to do that in a very affordable way. And so I believe that it really, the question that boils down to creating, even for the hospitals, a payment model that makes them want to reduce the use of their own facilities. And it really gets down to look at their margin, which is maybe 3% or 4% or something like that. That margin has to be sustained or improved while the larger amount, the other 97%, shrinks. And so you try to help them achieve what they need to do, which is a good margin, while at the same time achieving a total lower cost. That's a whole lot easier said than done, but I do believe we've made a lot of progress on that, and it has to keep going at a pace that's very similar to how they're able to change what they're doing. You can't get too far ahead, you can't fall behind. And I think that has been going reasonably well, but it is a long-term proposition.
Kathy, do you think the employer could have any clout in switching around our distribution of specialists in primary care?
Yeah, actually, a number of years ago, Dow worked on a gain-sharing model for person-centered medical home, and worked with our major insurer to, share the savings with the primary care physicians. And it was quite a struggle in some circumstances where the hospital, who employed some of the primary care physicians didn't necessarily want to share the savings with those physicians. So that was you know, and that is maybe an ongoing struggle because this program was implemented over a number of years. Now we are in about 20 states where we have significant employee population. But Dow really was the one in the community who went and educated the practices and the hospital systems in this model and person-centered medical homes. So we've done a lot in the community in that regards. And there are coalitions of employers who are also looking at you know, health plans and how to make contracts with health plans to ensure these kinds of models are, you know, are implemented. And one of the acronyms for one of these coalitions is CPR, and I'm trying to remember what that refers.
Somebody knows, what is it?
That's it. Yeah. And,
Say it again,
and there's
I
a
didn't
number of employer, you know,
CPR,
working on
Challenge
that.
for Payment Reform as well.
Challenge for payment reform.
Yeah, that's it.
Challenge for payment.
Oh, challenge.
So Dr. Bodnar brought up this topic of hospitals buying up medical practices. Unfortunately, we're out of time and can't go into that, so I'm delighted.
Maybe our next panel will get to
Yeah,
it.
yeah.
We're going to take a very short break and just change our panel and get them mic'd up. Please don't go far, maybe 5 minutes or so. But please join me in thanking our first panel.
Thank you. Thank you very much.